if anybody's on valproate and thinking of getting pregnant, please continue with the medication, but take advice. The most dangerous thing that can happen with valproate if somebody stops it abruptly without taking advice. So do not stop the valproate, but absolutely discuss it with your neurologist or your general practitioner. What are the problems? The pregnancy register was initially set up because there was a thinking that valproate caused large numbers of what are called major congenital malformations of the baby. What the register has shown over the last 10 or 15 years is that it does a bit, but only in about 3 or 4% of pregnancies. This is for congenital malformations, malformations of the baby, and it is much less likely to be a problem if people are taking less than 1,000 milligrams a day of valproate and they're taking valproate as the single epilepsy medication. So we were relatively comfortable about valproate, remembering that the background malformation rate for people not taking anything at all can be 1 or 2%. And people taking lamotrigine, carbamazepine, have a malformation rate of perhaps 3 or 4%. If my percentage points are slightly wrong, Aidan will correct me, but it's something of that level, I think.
I think it's closer to the norm, but...
Yeah. However, the problem that the European Medicine Partnership have brought up is nothing to do with major congenital malformations. It's to do with developmental delay. In other words, is the child that is born to a mum on valproate, is it as likely to do as well at school as somebody born to a mum who is not on valproate? In other words, the brain development, the development of that child. And there is increasing evidence to show that valproate can reduce the development, can reduce the potential of those children, and that is why this very clear instruction has come from Europe yesterday. So don't stop your medication, but please immediately go and discuss it.
I mean, I would just reiterate that as well. I mean, I think this is more and more, I think, at least from neurologists, I think we as a specialty are aware of this, and I think we would be very cautious. And I think for any young girl or woman to be started on valproate, that can really only be done in the context of where other options have been tried and failed, and only done in conjunction of following a detailed discussion. But I think actually, if you look at the global problem of the use of valproate in women, I don't think actually it's coming from, I think the majority of people on young women on valproate are actually not on it for epilepsy. They're actually on it as a mood stabilizer. And I think actually, so I think psychiatrists really need to stand up and take notice of this, because actually I think they, more than anyone else, are probably the biggest prescribers of valproate in young women. I think they really do need to take notice of what's coming, about this announcement. So of the anti-epileptic drugs, I think the great advantage of the pregnancy registers, and really what it has given us to what we didn't have before, we can confidently talk about drugs like lamotrigine and carbamazepine that really they do appear to be very safe, and that the rate of congenital abnormalities is probably not statistically different to that of the baseline population. Where problems come into it, and we know this, is actually when people are on polytherapy or they're on very high doses, and that's particularly true of valproate. But the key for valproate actually is not, and this has not been shown in any other drug. So they've done the studies that have looked at this. So the cognitive effects of these drugs have also been compared they've specifically looked at phenytoin, carbamazepine, and lamotrigine, and this effect has not been seen. But what does seem to happen with valproate, if you take a child, the biggest predictor of a child's IQ, the biggest correlation of a child's IQ is maternal IQ. And if you have a child on valproate, exposed to valproate in utero, you lose that relationship. So the prediction is that actually what happens is that the children's IQ tends to be lower than what you would expect given the maternal IQ. And like it or not, it is maternal and not paternal that seems to determine this. And I think that's really the fear, and that's really only come to light really in the last 6 years. The effect of valproate, the first major paper on this was published in 2009. So it's really only in the last few years. It's not the congenital malformations, because we know, yes, they're higher with valproate. Yes, they're higher if they're on higher doses and in combination. But what we really worry about valproate is actually the cognitive effect.
Is there programs that GPs can go to just to understand about epilepsy? Because I find with dealing with medications and whatever, talking to your GPs, they don't understand all about different types of medication.
There is a move, and I mean Henry is a classic case in point. So there are GPs who have a special interest or a subspecialisation in epilepsy. That, as of yet, has not happened in Ireland, but I think it will, and I think it's something that should happen. And I think that is the way, at least in my view, that general practice needs to develop. I think GPs need to develop subspecializations for them to actually continue to make a meaningful input. But you are right, GPs, and I think the problem for GPs is that the number of anti-epileptic drugs, there's now over 20 available anti-epileptic drugs, and it isn't really fair for them to expect to know that. But the standard model for the management for people with epilepsy is that it is one of shared care between neurology and GPs. So it isn't enough for them to say that they don't know. Then if they don't know, they at least need to inform, because they have to be involved. They have to be involved.
No, there aren't any courses in Ireland for GPs, but we're discussing them. Will GPs be interested in that? No, because we go on courses for ischemic heart disease, for COPD, for asthma, for diabetes, for dementia, for childhood immunisations, for travel back, all sorts of things. So the delight about being a general practitioner is we see a lot of everything. The problem is that if we spend time going on courses, we've got to get a payback for that course. And so when I've been helping on courses for GPs about epilepsy over the last 15 years, only a certain number have been interested because of how much work is involved in the practice. But yes, we're hoping there will be, but as Aidan said, it's very much a three-part process: patient, specialist and GP. And if you're on medication, it's very reasonable to ask for an individualised care plan, which is what you're on, what you should be doing, what you should be looking for. But also, that care plan should be for me to say, and if this happens, do this. If this happens, it could be the medication. So, but no, I'm afraid that epilepsy courses in general practice are very few and far between.
As neurologists, we have argued that actually it does seem to make an effect. It does seem to have an effect, switching from the named brand to a generic. Yes, I mean, I think as an overall view, we would take the view that really one should be prescribed the named drug or the prescribed drug rather than generic. And this has been looked at, and there does seem to be some evidence that it can affect seizure control.
Aidan's nearly right. If somebody is started on a generic, in other words, the chemical name of the drug, and your seizures are controlled, well, carry on with the generic. If somebody is on the formulation, then carry on with that, because the evidence isn't complete, but it would appear that the blood levels in some cases may change. So whatever formulation you started on, you should continue on. And the most the drugs that give us the most confidence about delivering the amount of drug on a regular basis is the name drug.
Okay. Yep, just here at the front. Oh, hang on, we have someone already. Sorry, I'll be back to you in a second.
Hello, how you doing? I'm just wondering, in relation to what Professor Smithson was saying in relation to social exclusion, is there any programs, or has there been any thoughts on putting programs into schools to teach the next generation, to make them aware about epilepsy, and the fact is not to be scared or run away from people or a child with epilepsy?
Thank you for that question. The people who will drive knowledge and education about epilepsy and reduce the stigma of epilepsy are people with epilepsy. And so if you're at school and you have epilepsy, I know that the Epilepsy Ireland have put together a quite excellent book, information booklet for teachers in schools. We also suspect that they're not read by a lot of teachers. But if you're at school and you have epilepsy, what I would suggest you discuss with your parents and say, do we take one of these booklets to the headmaster or our head of year or whatever and say, I want this read because I'm not ashamed of who I am, I'm not ashamed of the condition, what I am is burdened by people's ignorance. And so if you do that, you're the very best advocate for the condition.
And just to add, obviously, in terms of with Epilepsy Ireland, our regional staff around the country do a lot of work with schools. So if anybody does want Epilepsy Ireland to get involved or to speak with teachers or to make presentations in schools, our local offices are regularly doing that type of work. Okay, so the question is, can seizures affect the heart?
So short-term seizures, so again, the majority of seizures are brief, typically in the order of 1 to 2 minutes. There is a particular type of seizure where the seizures continue without interruption or fail to stop completely on their own. And that's known as status epilepticus, and that's a medical emergency. So what I would say is if you have a child or a person has a seizure for more than 5 minutes, they must go to hospital, because the physiological, the longer a seizure continues, the less likely it is to stop spontaneously. And the risk is if the seizure continues, it can have physiological effects both on the body but also on the brain. But if you were to ask, can a seizure itself in a sense affect the heart, damage the heart, the answer is no. But very, very rarely, seizures can be associated with cardiac arrhythmias or irregular heart rates, but they usually are self-limiting. So on a whole, the answer seems to be no, although there are documented cases of people having associated cardiac arrhythmias as a consequence of a seizure, and that usually necessitates management both with a cardiologist and a neurologist. But the key really is, it's not how violent or dramatic the seizure is, it's the length of the seizure and how long it continues.
Okay, Henry, any? No, okay. Just the back here.
Have you done a count in, my children have fetal valproate syndrome. I have 2 have fetal valproate syndrome and 1 pending. And I'm asking how many children in England are affected. Can you tell me that? And don't get me wrong, I'm not jumping down your throat. But what I want to know is, do you know how many over here in Ireland would have either fetal valproate syndrome or anticonvulsant syndrome?
So the first thing I say, I'm very sorry to hear that this has happened to you and your children. The answer is we don't know. That's not to excuse it in any way, but the data is just not. We just don't know what the data is. I think it is a very important question, and it's something we need to know. But I think more so, without question, you're not alone there. You know, this has definitely happened. There have been many cases that this has happened, and I have so personally met people that this has happened too. But I think, as important as it is to recognize how often it's happened, what is absolutely essential and is inexcusable is that to make sure that it never happens again. Empirically, yes, the answer is that if their first presentation with epilepsy is that of status epilepticus, they will invariably be put on treatment. The evidence, however, is that, so the evidence for treatment with seizures, and the reason why we define epilepsy as 2 or more seizures, 2 or more unprovoked seizures, is because we know that the risk of subsequent seizures is much higher if you've already had 2. If a person has 1 seizure, an unprovoked seizure, then the risk of having further seizures is probably in the order of 40 to 50%, which is why the established rationale is not to start treatment with someone after a single seizure unless there's compelling reasons to suggest that there will be a recurrence. The general view with status epilepticus is actually to treat because it's such a severe presentation, but actually the evidence, if you don't treat, is that the risk of subsequent seizures is probably comparable to that of a single unprovoked seizure as opposed to an episode of status epilepticus. So the answer is yes, they probably will be put on treatment, but the risk is probably similar to somebody with a self-limiting seizure.